Right, I think we'll make a start. So good afternoon and welcome to the BHF Data Science Centre's first monthly webinar of 2023, for which a record number of people have registered. And we'd like to say many thanks to all of you for making the time to attend today. My name is Reuven Preden, and I'm one of the Centre's research project managers with a focus on managing the CVD COVID UK COVID Impact Research Programme within our structured data thematic area, and I'll be chairing today's webinar. Today, we're delighted to welcome Professor Amitava Banerjee, who is a Professor of Clinical Data Science and Honorary Consultant Cardiologist at the Institute of Health Informatics at UCL, and Dr. Mehrdad Mizani, one of our very own health data scientists from the BHF Data Science Centre, to talk about their work to model mortality during the COVID-19 pandemic. Their talk is entitled Predicting Excess Deaths Among People with COVID-19 Using National Electronic Health Records. Before I hand over to Ami and Mehrdad, just to make you aware that this webinar is being recorded and it will be made available along with recordings from our previous webinars on the BHF Data Science Centre's playlist on the HDR UK YouTube channel. There'll be time at the end of today's talk for discussion, so please post your questions into the Q&A function and we'll do our best to answer as many questions posted as time allows. And finally, if you would like to present at a future webinar, do let us know in the chat and Kate McAllister, our communications manager, will follow up with you. Without any further ado, I'll now hand it over to Ami and Mehrdad.
Many thanks, Reuven, and thanks very much for your kind words. I'm just going to share my screen. Okay, so as Reuven said, I work at UCL in my academic capacity, but I'm a clinical cardiologist at University College London and Barts, and we're talking about excess deaths and how we've used this amazing resource supported by the British Heart Foundation Data Science Centre over the last couple of years. These are my conflicts of interest. I'm linked with various cardiovascular societies and a trustee of the South Asian Health Foundation and Long COVID SOS, and I spend 30% of my time clinically, and I've put my research funders up there as well. So it seems like a while ago, particularly as the government is talking about stopping certain ONS surveys and so on, but there was a time when every day we were confronted by dashboards, and we've never seen so much data, whether that was international COVID dashboards such as this from World Health Organization or our own data about hospital admissions and COVID mortality and so on. We got very used to these figures, and there was more interaction with data probably than we've seen in recent years. And you know, there is a whole social sciences research interest in whether that's sustainable to be kind of watching your data en masse in the public with this, which I'm not going to touch on. But where this work that we're going to talk about started is right at the beginning of the pandemic, when there were a few deaths, but there was already some predictions that that on the basis of the mortality in Wuhan and China and in Italy, that it might get bad quickly in the UK. And I had heard of this concept before, but Richard Horton in the Lancet started using this term syndemic, which originally was coined in the 90s, but rather than pandemic, which makes you think of infectious disease and infectious agents, this concentrates on the broader determinants, the interplay between not just social determinants, but non-communicable diseases as risk of pandemic as well. And this was on my mind, because the early data was showing clearly that people with heart disease, people who were older, were more at risk of dying from COVID. And in cardiovascular disease practice, we're used to stratifying people on the basis of simple characteristics, like whether they're diabetic, whether they've got high blood pressure. So I wondered whether people were doing the same for COVID. And electronic health records is a way that you can get at people's risk, whether at the individual level or at population level. And we know from the non-communicable disease literature, take heart attacks, for example, that most of the risk is accounted for by simple things like high blood pressure, like diabetes, like smoking. And so if the risk is predictable in cardiovascular disease, we thought, why not in infectious diseases as well? And excess deaths have been used for some time by various people, from policymakers to researchers to clinicians, to get a crude estimate of how badly a large-scale challenge to health or healthcare is affecting the population. So if you go back to 16th of March in 2020, there was a list of high-risk conditions that the Chief Medical Officer announced, including age over 70, cardiovascular disease, diabetes. And by chance, I saw a patient in the room I'm sitting in now with heart failure, who was concerned that he was generally well, but been told why he was wondering why he's been told that he's at higher risk of mortality from COVID. So with my colleagues, Laura, Harry and Spiros, we set about using some data that we had to hand for another project from CPRD, which is a large national primary care data set, which is linked with mortality data. And we set about doing analysis. And then on the 22nd of March, a further list of more vulnerable people, such as those who are post-chemotherapy, was announced. And we were in a position on that day to send our results to the Chief Medical Officer. And if you remember, the following day, we went into lockdown. So what we did in that preprint that we put out on the 22nd of March 2020 was we took these high-risk conditions, which are along the x-axis here, from COPD, chronic kidney disease, and so on. And you can see that in the general population, most of that group is the over 70s, 13.7%. But there is a big risk of various risk factors, over 2% of cardiovascular disease, 2% with diabetes. So there's a population of about 20%, a fifth of the population with underlying risk, high mortality from COVID. And the more risk factors you have, the more that risk is what we're showing in the right panel here. And some risk factors have more risk attached. And what Laura and I did with this analysis with Spiros and Harry was we were able to look at gender, we were able to look at the number of underlying conditions and age, and we, if you like, personalized people's risk. So the man who's under the age of 55, with no underlying conditions, his underlying risk is 0.1% per year of mortality, whereas a man over 85 years old with 3 underlying conditions or more has a mortality risk of nearly 30%. And then when you create a very simple model to take into account infection risk, so at that time we were talking about stopping the spread of infection, suppression, where you pretty much eradicate it to stopping most of the infection, to mitigation versus doing nothing. And at that time, we know from previous data that every winter we have an excess death rate of about 20% that we think is mostly caused by flu in bad years. And so there was already this debate about whether COVID was how much worse was it than flu. And so our base scenario was that COVID is the same as flu, in that it causes 20% excess deaths over the next year. And then you can see we went up to threefold worse than COVID. And we ended up with an estimate of about 70,000 excess deaths over the next year if 10% of the population got infected. It seems quite archaic now, but because so much more than 10% of the population got infected, but sadly over 200,000 people died with COVID. And this was covered in the press and informed the first UK lockdown. But when the study was published in the beginning of May, it still had relevance, because at that time we were deciding who should be further protected when we stop lockdown, who should be prioritized for treatments, how should we reduce that risk. And that leads to this work, again led by Laura, but also the HDR UK patient panel have been integral to this, where there's a huge interest in individual and population level risk and how we use that information. So Laura developed a quick way of personalizing your risk by putting in your data in 5 clicks about underlying conditions, age, and so on. In the model that I just described, you find out your baseline risk and your expected risk. And this was when we released it with the publication, used by 350,000 people in the first 24 hours. So there's an appetite for this. So I'm going to hand over at that point, because we have a model that we use to predict, but what you really want to know is whether it is useful, whether it actually can be validated. So Mehrdad is going to shed some light on that. Thank you, Mehrdad.
Thanks, Ami. Let me share my screen. Yeah, thank you, Ami. So I'm going to talk about the model that Ami mentioned and how we used TRE data, including primary care data and secondary care data of 35 million people in England over 30 years of age to validate this model. So our paper was, the results of this study was published in November last year in 2022. And these are excerpts from that study. This is again what Ami showed in their study in CPRD data, and called development study here. So it was a scenario-based study based on 4 different combinations of relative risk from 1.2 to 3, and different scenarios for infection rate, depending on the lockdown policy or the policies to prevent infection in public health. So just an explanation, a clarification of what we mean by modeling here. So this is not a machine learning modeling where you apply a model on a set of data and then take that model and apply that to another set of similar data in the future. This is a conceptual modeling, and we try to keep that simple and abstract here in this slide as a very simple mathematical model. So the relationship between excess death and baseline death can be explained here in this model based on infection rate and relative risk, and based on the actual value of relative risk of COVID, relative risk of death in people with COVID, and also infection rate of COVID. The actual ratio of excess death to baseline death could fall somewhere between 0 to 1 or 0% to 100%. And we tried to use, what we did in using the national data in trusted research environment was to find the actual observed relative risk and infection rate. This is the general steps that we took in this research. We had 35 million people over 30 years of age in England. We looked at their baseline pre-pandemic mortality rate using survival analysis. And then we used pandemic period data to observe what is the relative risk and infection rate, which is 4.34 and 6.27. And then we estimated and applied that conceptual method that I just showed to pre-pandemic based on results and compared the predicted or estimated number of deaths to observed values. So the design was a bit tricky because usually when you compare two groups, they are in the same period. And if you look at here, what we did here, this is a development study which was done in a period between 1997 to 2017. In this study, we compared the pandemic period to pre-pandemic period. Now, usually what you do is to take both groups, let's say case and control groups of people who are exposed to COVID-19 and are not exposed to COVID-19 in the same period. But since people who have not got COVID and have died, the death in this group also can be affected by indirect effects of COVID, like lockdown, changes in healthcare services. So in order to tackle this, we decided to take our unexposed group from pre-pandemic era. And in order to keep the ages quite close to each other, we just went back 1 year. Now, another complexity here is people who survive in this group will go on to be in the same case group in the same study. And again, to tackle this problem, we used a randomization technique where we divided the population randomly in two subsamples, calculate the relative risk and infection rate, the observed relative risk and infection rate in the pandemic period, and applied that on the mortality risk for pre-pandemic and then compare the results. So let me show you the results here. So as Ami mentioned, we were interested in the mortality risk, 1 year all-cause mortality in people who have diagnosed with COVID and have underlying conditions that by Public Health England were identified as high-risk conditions in COVID. And you can see that in previous websites on shielding list, including being over 70 years old of age, diabetes, cardiovascular disease, and so on. And also we included stereotherapy here for immunosuppressive diseases. For defining these conditions, we used phenotyping algorithms of Calibre, which is now hosted in HDR UK Phenotype Library, and also on the GitHub of our project, which was CCU003_03. You can find the phenotype definitions that we use for the study. For COVID-19 phenotyping and definitions, we use the results and the definitions in another study from the consortium that is mentioned here. This is the baseline 1 year mortality risk in people with these conditions and also with combinations of these conditions, people with no risk factors, 1 risk factor, 2 risk factor, or over 3, just to keep it in line with what was done in Ami's project in the first paper. And as I said, we used 2 different subsamples, and these are the examples of that. So we calculated infection rate in sample 1 comparing to sample 2, and also for risk ratio. And the average value is 6.27% of the population for infection rate. It means that of every 100% in the data, approximately 6.27 were infected as COVID. And the relative risk is 4.34. And it means that the risk of death in a year in people with COVID is 4.34 times more than the risk of death in people pre-pandemic. with the same conditions. And these are the results, again, presented in the same format that in the original paper. As you see, these are different age groups here, and the y-axis shows how many of these underlying risk factors each patient has, from 0 to 3+. And we applied this on NHS digital data based on observed values of RR of 4.34 and IR of 6.27. So we can see that what the model predicted was around 100,000 people with excess death due to COVID infection, but with all-cause mortality. And the actual value was 127,000. Now, the reason for slight underestimation can be attributed to many different things, including the limited number of SNOMED codes available in TRE for primary care data that can lead to underestimation of people with underlying conditions at the moment. But this underestimation is acceptable. And so there are other interpretation of this that we can discuss after the slides. That's my slide. That's my presentation for now. There are other slides here on sensitivity analysis that I can share in question and answer section. Thank you very much.
Thank you, Mehrdad. I'm just going to talk a little bit about the implications of this prediction model and this type of validation work. And just to open my slides again. So Mehrdad's work was, or the work that he led was with people across the consortium, and this is across the different nations' data, and I think on several occasions, many occasions now, we've been able to get data out and results out in preprint much quicker than getting to peer-reviewed publication, which it's important to get things peer-reviewed, but it's also important that this allows us the timeliness as well as the access to the data, this open access model. But also, this is not a UK issue. I wanted to say that this excess deaths was and is a way that countries around the world looked at their COVID mortality across different countries. And so this model was applied using global burden of disease data to different countries of the world. It's been used to prioritize for vaccination in Canada during the second wave. But I think what's really interesting is work led by colleagues at London School of Hygiene, Tropical Medicine, Charlotte Warren Gash in particular, and Jennifer Davidson, that this using of cardiovascular risk and underlying risk is not just for COVID. We might be looking at this for other seasonal infections. So in this study, we looked at the risk of respiratory infection and cardiovascular disease based on whether people had increased cardiovascular risk. And you can do this in the same way using electronic health records, just that you're looking at a different population with flu. So I think electronic health records and non-communicable disease epidemiology are part of pandemic preparedness. I also want to say that we've, since the beginning, Mehrdad mentioned indirect effects, but we've been able through the consortium to look at impact on non-COVID services as well. And so Alvina Lai led work early on looking at delays in cancer treatment. My colleague Mohammed in UCL has shown that there was a drop in the first wave across different cardiac procedures, but it's not just a cardiovascular thing. This has happened across all procedures, and what we've been less able to do so far, partly because every specialty and every procedure is gathering its own data, is look at the mortality impact of all of these reductions or changes in activity, in non-COVID activity during the pandemic. And Lucy Wright led work across a multiple institution, multiple partner project, which has been published in European Heart Journal, Quality Care and Outcomes. But we were able to look over 2 years of the pandemic across admissions, across different cardiovascular diseases, and show that in general there was a drop during the first wave, in particular a huge drop, but in many cases elective activity hasn't returned to normal, even in 2022, 2023. We talked about excess deaths in the COVID pandemic. Long COVID reminds us that non-death or morbidity is an important thing that we need to get better at measuring using our data, from the infection prevention up to whether people are recovering. And just to say that this is affecting over 2 million people, the Office for National Statistics estimates, which is comparable with most of the chronic diseases that we know of. And the data that we have in the trusted research environment here, linked data across primary, secondary care, across administrative data sets, is really important for this relatively new idea of a learning health system, which we've been able to apply to COVID, thinking of direct effects, which is the prediction of direct deaths, but the indirect effects that I just mentioned, but also the long-term effects. And within that, a disease like cardiovascular disease or other chronic diseases can be both risk factor and outcome. And as well as individual projects, we need to think about where this fits in and how we use our data better. And right now, there's a crisis in the NHS in terms of the waiting lists, in terms of the pressure on staff and services, and we need to think about whether it's due to indirect effects, a drop in prevention and treatment of diseases like cardiovascular disease. Is it to do with the winter flu? Is it ongoing COVID? And I think it's this kind of approach, using linked electronic health records, which is really important to not only get that answer, but prepare for future emergencies. And I think what's worked really well is having people from different groups, whether it's clinicians, researchers, or patients and public, involved in setting those priorities. So I think this is my last slide, that I think this work has led us to think that, when we get out of the pandemic, we need to have access to this type of data to be able to push forward in science, evidence, and care, to be more proactive, less reactive, more preventive, but also it will help us think more holistically in this syndemic lens. Thank you very much, and happy to take questions.
Many thanks, Ami and Mehrdad, for that fabulous presentation. We'll go to Q&A now. Firstly, there's a couple of points from John Cleland, who's got some queries about some of the numbers that were used within the presentation. So firstly, he's asking whether there are 57 million adults in England as per the Lancet paper trial, and also questioning whether it was 6% of the population that got COVID-19.
Yeah, so to the first point, we extrapolated, John, from CPRD data to the whole population in the UK, and we can we know that there are problems in doing that extrapolation, but we were doing something that was a prediction and a projection, right at the beginning of the pandemic. What we can do with a fuller data set, like the full linked data set in the trusted research environment, is look to the actual numbers where Mehrdad, correct me, across all 3 countries, how many adults do we have?
Well, in terms of data, we just looked at England, but I just need to clarify that this is not exactly census data. So although it's population data, it is collected from NHS practices and from hospitals, but this data also includes these 1.3 million opt-outs, and also there might be records that are duplicated, people who are deregistered, but they are still in the system, and this has reflected into data. So to answer this question, we apply different quality control measures to drop the number of records that we that based on modeling and quality control modeling seems to be incorrect. But in this study, we just looked at England, Amy, and for people over 30 years of age, it was around 35 points.
Thank you for correcting me. On the 6% thing, so there's several issues there. So first of all, not everybody who's got COVID gets tested, and we're looking at confirmed infections here. So if anything, this is, you're right, John, this is an underestimate, and possibly a big underestimate. But the fact that you can still see such a large burden of mortality is of course a concern. But then later on, as testing became not as accessible, and people had to pay for it, we've seen an even probably a lower estimate, or it's harder to tell what the exact infection rate is. So we're led by samples in that respect.
One other additional thing about data-oriented explanation could be, now at the time of this study, well, the data now is more complete and reflects the reality better. At the time, the new SNOMED codes or ICD codes were defined, and until they reflect into practices and hospitals, and until it's reflected in data, it might take a while, a couple of months. So probably now, if we look at the infection rates, it would be more realistic, but at the time, this is what data showed.
Okay, next point. So Dan B says, there is currently an analysis of excess deaths in the context of vaccination side effects. He asks, is this good research?
I think if you're asking, should we be looking at whether vaccinations cause excess deaths, there's a lot of misinformation, including from some within the clinical community, that there is a burden of excess mortality that from vaccination that outweighs that from COVID itself. So the best way to show that that's not the case is with data and by doing the research. So I would say it's good research to do that, as long as it's done properly using the best linked data.
Thanks, Amy. Neil Postlethwaite asks, what happens to the model when you reflect COVID infections themselves actually causing some of these underlying conditions and risk factors going forward, such as diabetes or cardiovascular or kidney problems? Does the model predict accelerating excess deaths?
So the initial model was very simply looking at underlying risk of for 1 year mortality, all-cause mortality, and making an assumption about infection rate and making an assumption about the relative virulence or worsening of mortality with COVID. Now, whether it's vaccination or whether it's the effects, you say we need to see what those effects are when you add them in as sensitivity analyses. I think we're starting to see meta-analyses of what the organ-specific effect of infection is, but it's hard to get an exact number on that because of the differing study designs. You know, for example, what's the risk of cardiovascular disease post-COVID? Which cardiovascular disease are you looking for? So, and then also, I'd say this kind of model was meant to be something that's easy to use, and we want to see how we can keep it simple, but we'd be happy to do that kind of work as follow-up and sensitivity analysis work. Mehrdad, did you want to add anything?
No, nothing from me. That was great. As Ami said, these were two different study designs, and here COVID-19 was the exposure, and we looked at the outcome that would probably be related to long COVID and how to look at it vice versa. But yeah, nothing to add to Ami said. Thanks, Ami.
Thanks to Dr. Piadlo for the comment saying that this is a prime example of how data can save lives. So thanks for making that comment. John has another question, but we have another one which came separately, which is a question about the next steps for this research and how do you prioritize what questions to answer next?
Mehrdad, do you want to start?
Well, I think in terms of doing next steps for this research, it would be conducting the same research on the stratified different age groups. So here we have applied relative risk and infection rate overall across all ages, although we have calculated for different age groups, but the model has kept simple. So the first validation was just very simple based on what was done quickly at the start of the pandemic and showed to be a good estimation. And again, just based on overall estimation of RR and IR, it showed to be close to realistic numbers. So the next steps would be to do a more stratified and detailed analysis on this study, and also to kind of connect this to long COVID project and for the new questions that now are more relevant probably rather than the first of pandemic.
I would add that I think there's three ways that I would see next steps taken. One is to look under the bonnet at particular high-risk conditions or particular populations and see how well this kind of prediction works in, say, people with kidney disease versus people with cardiovascular disease versus other risk factors, to see if there's that difference is explainable by some of the things that people are saying, such as vaccination and so on. I think secondly, we've seen that the mortality associated with COVID changed greatly based on vaccination, based on education, and based on changes in infection rate. And so that inevitably will lead to changes in the model itself. I don't think we expect that the same model will apply from the first wave of the pandemic to right now, and I think it's important to incorporate other things. But and then I'm interested in more of a debate, a conversation about how we prioritize what we do, because a big data resource such as the CVD COVID consortium, even with all the researchers involved, has limited analyst capacity, limited capacity of researchers. So how do we set the right questions which are most important for policy? And I think there's a reactive and a kind of proactive arm to that.
I think we've got time for one more question. So I'll go to a question from Ashley Akbari, who asks, have you thought about how this work could be deployed back into the NHS? as a potential risk factor identification, primary prevention in the future.
Yeah, thanks for that, Ashley. I mean, we do this in cardiovascular disease already, and for NHS health checks with things like Q risk, and we've had this approach across diseases so far, where for every disease, whether it's heart failure or rheumatoid arthritis, we develop our own risk scores for that specialty, and this type of work has the potential to kind of use those same simple risk factors across diseases to predict. So I'd be really interested in talking to you about that, about how we can do more translational work.
Thanks, Ami and Mehrdad. So in the interest of time, we're just about to use up our time for today, but I just wanted to thank Ami and Mehrdad for presenting today, and to everyone who's attended. So we had over 100 people register for today's webinar, which is a record for us so far, and over 70 people actually attended. So thank you everyone for attending today. And I also understand that there might have been some joining issues at the start of the webinar, so apologies to anyone who had trouble joining. Just to finish by saying the next webinar will be held on the 8th of February, and registration details will follow in due course. So thanks everyone for joining today, and enjoy the rest of your day.